Now, what I would be sharing is what we as small standalone labs face when, you're sitting amidst general practitioners or family physicians, as they call themselves, who want everything on a CBC. And we have very minimal support of any specialized investigations, because the affordability comes as a major factor. So I would rather put it as, when you have more sensitive and specific diagnostic tests available, the basic tests are actually losing their sheen. But when you sit as a standalone lab, you face all those problems wherein everything narrows down to the pathologist, and you are expected to give a diagnosis just looking at the CBC smear. So the problems that we were facing was, during the dengue, chikungunya season. Now, both are vector-borne, both present very similarly, and the differences don't really appear in the early 48 to 72 hours. It's only later, after say third day or something, patient comes up with severe joint pains, and their diagnosis can be made if the specialized tests are not undertaken. The problems that we face is that, the symptoms are very similar, and in chikungunya, now the first 5 to 7 days, there is no serological test that can detect the virus. The only answer is PCR, which is practically a difficult thing when you start dealing with finances. Dengue, we do have NS1, but a lot of false negatives also we did get, because they insist on doing a rapid test and not even an ELISA. The third thing in the same season that we come across is the typhoids, wherein again the first week none of the serological tests come positive. So since we did not have access to the specialized investigation for most of our patients, we started looking at the CBC pattern carefully, and something odd that appeared was some of the tests, some of the patients had neutrophilia. Now, in a season of viral infections, finding neutrophilia was odd, and then we started looking at the neutrolympho ratios, which were considerably elevated. Now, CBC can really be of use, because we have the basic ratios that can be calculated from a simple CBC. So the neutrolympho ratio, calculated either using the absolute counts or the percentages, can be handy. Only problem is that, there is an effect of stress on NLR, because the moment the body is exposed to stress, there are a lot of endogenous catecholamine release, which increases the neutro and decreases the lymphocytes. Plus, it depends on the clinical context, wherein we presume that a normal NLR of 1 to 3 is considered a normal. 6 to 9 could be a mild stress, and 9 or higher would be seen in critically ill patients. Increased levels of cortisol do cause an increase in neutrophils, endogenous catecholamines, and cytokines. They all cause increased NLR. Now, the utility of NLR is not solely as an indicator of infection or inflammation. Any physiological stress can alter this parameter, and it increases very rapidly following acute stress. So, we need to make use of the body's response. Now, what happens in chikungunya is that, the mosquito bite induces a neutrophil activation. NLR has not been, I could not find much of data related to chikungunya, but it has been studied in many other conditions, and every condition, specific cutoffs have been identified, and they have been defined so that, the risk and the prognostication can be done. Inflammation that occurs actually causes the neutrophil recruitment, and that releases the chemotactic factors. Now, this has been used as the marker for septicemia and critical inflammation, wherein the ranges have been defined. Now, a normal NLR is considered to be 1 to 2. More than 3 and less than 0.7 is definitely considered pathological, and 2.3 to 3 may serve as an early warning sign. For many conditions like cancer, atherosclerosis, infection, inflammation, psychiatric disorders, and stress. Similarly, we have a platelet lymphocyte ratio that we have been observing. Now, this is calculated as absolute platelet count to the absolute lymphocyte count. 95% reference range of 36.63 to 172 has been considered normal. Now, in chikungunya, there is the neutrophil extracellular traps are not documented. So, it is not the neutrophil extracellular traps that start working. What works is the TLR7 activation, which releases the reactive oxygen species. And there is a decrease in IL-8 levels, which is ideally supposed to lower the number of neutrophils and increase their numbers in skin. But actually, what we practically observed was something slightly different from what has been reported in earlier studies. Then a neutrophil stimulating factor has been reported, which is released by the mosquito saliva, and that activates the neutrophils, and that causes neutrophilia in these patients. Now, the other chemotactic factors also come into play, and then the mosquito saliva also causes mast cell degranulation. So what we did in this was we started closely observing the CBC trends and started making a retrospective comparison of all the chikungunya PCR positive cases with their CBC findings, because what we were observing was there was a neutrophilia that was a common factor in most of the chikungunya PCR positive patients, and platelet counts were definitely not falling. So NLR and PLR both were studied, and retrospectively we did a t-test, a chi-square test, and a logistic regression to see how we can study the impact of chikungunya on these factors. And then the R-square was calculated to see if there is actually a significant association. And lastly, we did a multivariate analysis where we compared our NLR and PLR simultaneously with our control group. Now, as such, in our patients in chikungunya, a mean of 9.5 NLR and PLR of 361 was reported, which was much higher than what has been reported as normal. And the percentage of patients coming with this was very high, that is 92% of our patients were actually having a very high NLR. Similarly, PLR was high in 88% of our patients. Then a t-test was run, and the values were found to be significant. We did the calculations were done, and a predictability of 91% was observed. Similarly, for PLR, it was 86%, consistent with our hypothesis that there could be an association. Then a chi-square test was done, grouping the data based on the normal ranges that had been identified and defined earlier. This was not based on the data on our lab findings. This was done based on the defined ranges, and chi-square tests were significant. Then a positive predictive value was calculated, and a positive predictive value of 96% was obtained for NLR and 75% was obtained for PLR. Now, all this indicates that NLR and PLR both have a very significant association, and then the R square was calculated. Now, this R square is basically as close as it is to 1, indicates a higher association with the disease, and NLR was 0.845 and PLR was 0.685, which meant both of them could be used as predictive markers to at least advise a higher test. But smaller things have a bigger impact. When we did a multivariate analysis, the PLR was not significant, because the p-value in this case in the multivariate analysis came to be 0.963 and a significant value is less than 0.05. So that meant that it's not just one parameter that affects it. There are multiple things that play a role in the body, and I did go through the literature, and I found that the interaction of platelets with the T lymphocytes reduces the lymphocyte proliferation, and that decreases the pro-inflammatory cytokines, and that has an impact in reducing the influence of PLR as a predictive marker. So individually considered, they are both predictive markers, but practically when an individual is considered as a whole, the role of PLR is much lesser as compared to NLR. The multivariate analysis was definitely a better eye-opener for us, and NLR was a more sensitive and predictive marker for taking into consideration. So now the NLR and PLR have a role, but when considering the individual as a whole, we need to look into further research that goes on, and definitely to be considered in concordance with the other clinical parameters of the patient. So an alert mind and a keen observation can help in directing the clinician to advise a specific test rather than requesting for a combo of the prevailing diseases, and definitely nothing can undermine the sensitivity and specificity of the specialized tests that are available, but definitely this is a boon for people who are fighting with resources to get a diagnosis. I had shared 115 cases, out of which 70 were from my lab, 27 were from Dr. Gaurav Agarwal's lab, 18 from Dr. Anshul's lab, that is lab expert, and a special word of thanks to our statistician, Dr. Neha Shroff, who helped us out with the statistics. Thank you.
I have a comment for you.
Yes, sir.
I am used to do logistic regression, and in this case, because both parameters are divided by lymphocytes, I recommend to use an NLR and platelets with logistic regression, or PLR and
neutrophils.
Yes, absolutely. And try that. And also, the third experiment is to try platelets, lymphocytes, and neutrophils in logistic regressions to see which formula it proposes you. The
individually, they are all significant predictors. This is what we observed. But practically PLR had hardly any significance because PLR was normal in all the cases, and even the control group, we had a lot of normal PLR patients. So that is why, the multivariate analysis actually rejected that possibility of it being a predictor.
Yeah, yes, this is the reason I make the comment, because I think both parameters have very good utility, but maybe to combine them is better to eliminate lymphocytes from the second one. And that is what I propose you to do.
Sure,
and,
sir.
and
I'll do
maybe
that.
you will share your results with us. Thank
Sure,
you.
sir. Yeah.
Thank you.